sort of flesh that out a little bit, monotherapy or dual therapy, and now we have this LAG-3, and how do you choose? And what is your decision-making process, basically?
Yeah. And again, this is another area where it's a lot of opinions and a lot of really individualized, sort of decision making between the patient and their oncologist, because we really don't have head-to-head trials, comparing what you just, basically refer to these three regimens of just a single agent PD-1 inhibitor. Then we had IPI and Nivo.
Sure.
And then the newest, sort of combination on the block is the LAG-3 with Nivo-Rela. My view is that we don't have a perfect therapy. There is no perfect therapy. So it really is about weighing risk and benefits. I do think most patients, again, not all, but most should probably get a combination immune therapy. That's, sort of our bias at Duke. In general, we typically see response rates that are numerically higher. And we have a trial, of course, comparing Nivo-Rela versus Nivo, where the combination was superior, at least in terms of progression-free survival. But the flip side of that coin is the toxicity. So with Ipi-Nivo, we see a pretty big jump in some of these potentially serious, what we call immune-mediated adverse events, but basically, the side effects that we get from the immune system sort of turning on the patient's own body. And some of these can be very serious. So a little bit of it depends on kind of patient tolerance for risk, how healthy they might be, other medical problems they might have. A little bit of it too, more than a little bit, depends on, the extent of their disease,
Sure.
and how we kind of balance that risk and benefit.
Yeah, I think this is a really not an easy decision to make, right? And you talked about a number of different determining factors, such as extent of the disease, the patient's own health, other comorbidities, right? And also the risk tolerance. And obviously, we sort of touched upon this because monotherapy, when you talked about, so one of the questions maybe that your patient is asking you is, you talked about progression-free survival seems to be a little bit better with the dual therapy. But what about overall survival? Does the data show that dual therapy is better?
Yeah, it's tricky because of the way some of these trials were designed. Um, and, there's statistical significance, and then there's, clinical significance and parameters in the real world, kind of day-to-day practice. And I think, it's to be fair, there was not a statistical difference, even though there was a trend, towards improvement with Nivo-Rela versus Nivo. We, of course, have a trial looking at Ipi-Nivo, Nivo, and Ipi. And that trial, the way it was designed, it was really comparing the PD-1 based regimens to Ipi, which was the standard at the time. And that's not something we use a lot, by itself anymore. We really use it with, the PD-1s. But numerically, we have really long-term follow-up data, from these trials. And we know that for sure that patients with a PD-1 based regimen do better than patients who get Ipi by itself, which is why those therapies sort of jumped ahead of
Sure.
Ipi, even though that was the first checkpoint inhibitor to bear. And we do see numerically higher response rates with combination therapy. We do see numerically, higher numbers of patients who are alive. But at the same time, there are just questions about how we sequence these therapies. Like, for example, could you treat someone with PD-1 monotherapy, and if they respond, wonderful, but if they don't respond, maybe then they could get, Ipi-Nivo if they're worried about side effects. So we certainly realize we're over treating, probably some patients to try and, capture the benefit for as many patients as possible. But because we don't have a biomarker, to select these patients, it's largely a clinical, judgment and a detailed discussion with each patient.
I mean, what is that process? I mean, like, how does it, by the time you finish the discussion, right, and you share the pros and cons, everything, a lot of patient probably will feel overwhelmed at that point.
Yeah.
Do they just turn to you and say, Doc, what should I do? Is that usually how this conversation ends?
It depends. I think patients come to us at different points in their journey. I think a lot of patients do come to us for a recommendation, and I think that's an important part of every conversation that I have with a patient. So I never, put things out there and just say, let's just choose. It's not multiple choice. But I really view the consultation as a chance to get to know the patient, a chance to see the kind of questions they're asking, a chance to a little bit to learn more about their goals of their care. And then when I have that information, I can usually help them, between the various
Yeah,
flavors,
yeah.
if you will. I can usually help them, kind of make a decision about the therapy that's going to be the right fit for them. Or if, they're not sure, I'll make a recommendation and I'll tell them why. For example, if I'm hearing someone, they're asking a lot about side effects, they're really worried about making trips back and forth and getting to the hospital. Maybe they're older, maybe they, have other things going on. I tell them that I hear you saying this, that if you were to get a side effect, or that, this would really impact things. And, so because of this, maybe we should take a therapy that maybe not as many people respond to, but also is a lot better tolerated. And I make sure that really they hear that and that sort of sits well with their value system. And sometimes people say, no, that's not what I mean, so
Yeah,
I
yeah,
really
yeah.
think that informed decision is just so key.
No, I think you're so right about this process, right? I mean, I think one of the most important element about getting good prognosis, getting good care is that patient-physician relationship, right? And then I think, medicine is not kind of an algorithm. You just you have X, Y, Z, you choose this, you choose that purely based on number. It's what you're doing is so great because you're trying to basically figure out that person, figure out the individual needs, both the medically and socially, right? And that makes a huge decision. Shifting gears a little bit.